cells. And this mutation results in a clonal expansion of undifferentiated myeloid precursor, which is myeloblasts in the peripheral blood and bone marrow, resulting in effective erythropoiesis and bone marrow failure. Uh, However, these myeloblasts also can be separate not only into the blood vessel, but also can go to other soft tissues such as gums, CNS, as well as can become a myeloid sarcoma. So there is actually no specific symptom for acute myeloid leukemia. Patient usually presented with weight loss, fatigue, fever, night sweat, and appetite. Other typical signs that we can see in AML patient include fatigue, lethargy, headache, giddiness, pallor, shortness of breath, infection, and often come with fever. Also, because of the low platelet, patient can come with bleeding tendency as well as gum swelling when the myeloblast went into the gum, as well as hepatosplenomegaly. So, what is the risk factors for AML? Usually, the median age is around 67 years old, although younger people also can develop this disease. Gender men at slightly higher risk compared to women. Smoking, long-term chemical exposure such as benzene, chemotherapy, radiation exposure or radiation treatment for cancer, has underlying blood disorders such as myelodysplastic syndrome and myeloproliferative neoplasm, especially in myelofibrosis, genetic syndromes such as Down syndrome. A close relative, parent, or sibling with AML doesn't appear to have a strong link to hereditary, but genetic and chromosomal changes that occur during one lifetime can be a risk factor. So, for classification of AML, diagnosis and classification of AML have significantly changed in 2022 with the newly proposed WHO 5th edition, which called now WHO 2022 and International Consensus Classification ICC. Both of these classification system emphasize integration of clinical, molecular genetics, morphologic, and immunophenotypic parameters to provide evidence-based classification of AML to facilitate the precision diagnosis and prognostication treatment and allow the design of innovative clinical trials for AML. So this is the new classification of AML according to ICC 2022 and WHO 5th edition 2022. In ICC, there is a change of the threshold for the blast count to diagnose AML with the genetic mutation that can be found, similar with the WHO as well. Both emphasize on the use of the genetic or mutations. So for the European Leukemia Net, ELN 2022 were also updated and represent the current standard of care for AML patient risk stratification. ELN 2022 also recommend on MRD include new technical recommendation for standardized multi-parameter flow cytometry MRD and molecular MRD analysis, MRD thresholds, definition of MRD response, and suggestion for clinical implication. So this is the 2022 ELN guideline for the diagnosis and management of patient with AML. For patient at diagnosis with the new case of AML, emphasized to be screened for genetic analysis, which include cytogenetic screening for gene mutation required for establishing the diagnosis, and screening for the gene rearrangement with the preferably LTAT for each test. For example, for cytogenetic ELN 2022, prefer the result to be ready within 5 to 7 days. And for FLIC3 and NPM1, the preferably LTAT would be 3 to 5 days. So this is 2022 ALN risk stratification of AML by genetics, which subdivide the genetic group into favorable, intermediate, and adverse. For example, FLIC3 mutation now not included in adverse genetic groups anymore. It is now located in the intermediate group. For favorable, there is like 4 genetic mutation that can be subset into translocation of 821, which produce the RUNX1 RUNX1T1 fusion gene, inversion 16 or translocation 1616, which produce CBFB-MYH11 fusion gene, mutated NPM1 without FLT3-ITD, and also in-frame mutated CBBPA. Whereas in intermediate group, include the mutated NPM1 with FLT3-ITD, wild-type NPM1 with FLT3-ITD, the translocation of 911, which produce MLLT, KMT2A, and also cytogenetic or molecular abnormalities which is not classified as favorable or adverse. So for adverse, include the infusion 3 translocation, 6, 9, and etc. So BSH 2023 guideline also recommend for laboratory testing of UK with patient of AML. For cytogenetic AML, it usually very critical at diagnosis and relapse. So where indicated, PMA-RARA testing also must be completed within 24 hours of sample. By BSH 2023 guideline, it emphasized on the LTAT for each test that include the FLT3, NPM1, and also for other fusion gene screening. For FLT3 and NPM1, BSH guideline suggests that this test should be completed within 3 days so that the FLT3 inhibitor can be given to the patient as soon as day 8 of treatment. And also a complete conventional cytogenetic analysis is required within 7 days of sample receipt. Molecular MRD assessment should be performed for patient with NPM1 mutation, CBFB, MYH11, RUNX1, RUNX1T1, NPM RARA fusion, and should be considered for other fusion gene. And suspected germline findings in the cancer susceptible gene should be highlighted in the genetic report. So for the treatment of AML include the induction therapy, which the purpose for this is to achieve complete remission, and usually anthracycline, cytarabine, FLAG-IDA, and Mylotarg can be used for induction chemotherapy. Midostaurin can be added for FLT3 mutated AML, which will be given at day 8 of treatment. After attainment of the complete remission, consolidated therapy will be proceeded and patient will be consolidated with regimens that include intermediate dose cytarabine. Once the complete remission is also attained after the consolidation therapy, maintenance therapy will be proceed, which usually consists of minimally toxic therapy capable of reducing risk of leukemia relapse. However, AML is usually associated with high relapse, especially in the elderly. This is because of the refractory disease, relapse disease, or even complication of the disease and treatment, which include bleeding, infection, and metabolic. Therefore, because of the higher relapse rates in AML, there is often intense treatment with high-dose chemotherapy followed by rescue using allogeneic stem cell transplantation in first complete remission. Allogeneic stem cell transplant reduce risk of relapse, but there is often high transplant-related mortality, especially in older patients and those transplanted with non-HLA identical family members or unrelated donors. Therefore, reduced intensity conditioning transplant is usually reserved for older patients, and the role of autografting in the management of AML is still contentious. So now I come to the MRD, measurable residual disease. This term started with minimal residual disease, now changed to measurable residual disease. So actually MRD is defined as the persistence of leukemic cells after treatment at levels below morphologic detection. MRD is very important for risk stratification and treatment planning. Detection of MRD by any methodology during morphological remission after standard chemotherapy is a strong prognostic factor for subsequent relapse and shorter survival in patients with AML. On the other hand, MRD below certain threshold is associated with longer progression-free survival and overall survival patients with leukemia. So achievement of MRD reduction below defined threshold at key time point during treatment can indicate risk of relapse and guide treatment intensification. However, the relevant threshold is differ between molecular subtype of AML. And it is essential that results are consistent across laboratories and reflect those from clinical trial labs for clinical validity. And robust procedures should be in place to avoid false positive and false negative result. So AML MRD assessment is important. First, for prognostication, where MRD during morphological remission after standard chemotherapy provides strong prognostic factor for relapse and shorter survival by provide a quantitative methodology to establish a deeper remission status. Number two is predictive. By doing AML MRD assessment, it refines post-remission relapse risk assessment and also predicts early relapse. And also MRD helps in monitoring patient in guiding post-remission therapy and able to identify impending relapse to enable early intervention. And also for efficacy response, this is important because AML MRD is used as a secondary endpoint in clinical trial for developing novel regimen to accelerate drug testing and approval. So now there are few technologies for AML because as we know, morphology, cytogenetic, and FISH are relatively insensitive technique to detect residual disease. So at the moment, two mostly extensive, evaluated, and validated methodologies for clinical decision making in routine care are multi-parameter flow cytometry-based MRD as well as molecular MRD, which is usually assessed by real-time PCR. Another emerging exploratory molecular approach for technologies are next generation sequencing, NGS-based, and digital PCR. So for multi-parameter flow cytometry, this is the most commonly used MRD detection methodology and helps in randomized treatment comparison and MRD-directed therapy. So in flow cytometry for MRD, we use the integration of diagnostic leukemia-associated immunophenotype (LAIP) that can distinguish AML cells from normal hematopoietic cell in individual patient, and also more generally define different from normal GFN, which use the aberrant phenotype approach to allow both for tracking of diagnostic and emerging clones. And both of these integration should include core markers of immunophenotype. However, both approaches require expertise in the recognition of aberrant population and exclusion of potential background as part of assay validation. So ideally, a diagnostic sample is preferred to determine whether has diagnostic flow cytometric MRD target can be tracked, and it should be performed with a qualified assay based on guideline for a rare event detection. At the moment, evaluation of the residual leukemic stem cell by flow cytometry is still investigational, but is recommended for evaluation in clinical studies because the prognostic value of leukemic stem cell by flow cytometry has been associated with higher sensitivity on and lower false negativity. Number two, technologies that we use for MRD nowadays is molecular-based MRD. The technique used include real-time PCR, digital PCR, and NGS. And this molecular-based MRD should reach a limit of detection of at least 10 to the power of 3 or lower with technically validated assay. For the sample, it is at least we have to use 10 mils of peripheral blood and depends on the white blood cell count, or 5 ml of bone marrow may be used. However, the sensitivity in peripheral blood is generally lower, approximately 5 to 10 fold lower compared to the bone marrow. Either ADTA or heparin can be used as the anticoagulant on sample for molecular MRD analysis, but please note that there is a potential inhibitory activity of heparin on PCR reaction. Therefore, anticoagulant effect should be assessed during assay validation. So for molecular base, I subdivide it into the real-time PCR-based molecular MRD assay and NGS. So for molecular MRD analysis for NPM1 or fusion genes is usually performed from the RNA or complementary DNA because of the high expression of the genes and thus better sensitivity. Leukemia-related abnormalities that suitable for real-time PCR monitoring include mutated NPM1, CBFP, MYH11, RUNX1, RUNX1T1, PMA-RARA, KMT2A, MLLT3, DEC NUP214, PCR-ABL, and WT1. However, WT1 is a less specific marker and can be found largely in bone marrow. Validation is most robust for NPM1 mutated as well as CBFB-MY H11 and RUNX1T1 positive AML. So for NGS-based molecular MRD, we use the error-corrected targeted multi-gene panel-based approach preferred. In this case, we monitor the variant allele frequency of variant detected at diagnosis versus reporting the emerging of new variant. So DNA is used for NGS. However, care must be taken to recognize and exclude germline mutation, such as presence of VAF of more than 50% in genes of ANKRD26, SEPA, DDX41, ETB6, GATA2, RUNX1, and TP53. This gene should be excluded as MRD marker because it is non-informative for MRD as well. So mutation consistent with pre-malignant clonal hematopoiesis such as TET2, ASL1, DNMT2A should also not be considered as MRD. And further study is required to identify and distinguish truly indicative of residual AML from clonal hematopoiesis-related abnormalities. However, it is important to note that at the moment, NGS-based strategies currently lack of standardization as a standalone technique for MRD assessment. So even in Manchester, we don't use NGS as a first line for MRD assessment, but they are trying to standardize the NGS. So this is the example for NGS-based molecular MRD done in St. Mary Hospital. This is NGS done at diagnosis. For example, in this case, there are 4 variants detected at diagnosis, which is PT, PN11, CBL, FLT3, and KRAS, with PTPN with a VAF of 22, CBL 7%, FLT3 5%, KRAS 3%. So for the subsequent NGS, which will be done post-induction, they will monitor whether the VAF of this variant, either it is increased or reduced or even diminished, or presence of new clone or new variant. So this is what they call NGS-based molecular MRD at the moment done in Manchester. So this shows the methods for MRD detection in ML comparison, compare to each method, target, sensitivity, and also the limitation and problem. For example, the most sensitive MRD is molecular, where the sensitivity is around 10 to the minus of 4 to 10 to the minus of 5, whereas for NGS and digital PCR is still exploratory. However, for using the real-time PCR, there is a limited applicability to monitor the MRD as compared to multi-parameter flow cytometry. For NGS, it is less sensitive because the sensitivity is around 10 to the minus of 2, and this is costly method and also technically challenging. So implementation of MRD testing, various studies have shown the prognostic value of MRD for relapse and overall survival. Although MRD estimate clinical prognostic insight, they are imperfect because relapse still occurs in a minority of MRD negative patients. Therefore, negative MRD test result may not indicate complete disease eradication but refer to disease below the MRD test threshold in the tested sample. Conversely, not all patients who are MRD positive will relapse. For instance, in CBF AML, which is AML with RUNX1T1 and AML with CBFP MYH11, as well as NPM1 mutant AML, the transcript may show persistent low level expression after treatment, but this is not prognostic of relapse. Of note, molecular MRD may remain detectable at low level without prognostic significance and therefore are called negative operationally if MRD values are below the threshold linked to the prognosis. And the presence of detectable MRD before transplant is an independent unfavorable predictor of post-transplant outcome. So let's Now I'm going to share the experience in a molecular hemato-oncology unit, genetic diagnostic laboratory, St. Mary Hospital, Manchester. So this is the request form for molecular genomic testing. As you can see here, there are few testing that offered by the lab, which include myeloid NGS panel, consists of myeloid panel, lymphoid panel, as well as SNP array and RNA fusion panel, and others. As you can see, MRD offered is infusion 16 with CBFB MyHe 11, Run X1T1, PML RARA, and NPM1. This is for AML. This is the request form from other hospital that send their sample to St. Mary Hospital lab. For example, this is not for MMRD, but this is just show another sample of request form. Okay. When the samples come to our lab, we need the clinical scientists on duty need to do the second checking after the first checking done by the lab technologists. We must check how the scientists on duty must check what type of sample come, either peripheral blood or marrow, how many tube, and the volume of the sample, and the date of the sample taken, and also what type of sample need to be processed, either RNA or DNA. And at the back of the form, we need to list down the tests need to be done, name of the scientist on duty, date of the sample triaging, and also we need to define again what type of test we want to do, either using RNA or DNA. So this is the AML pathway for sample triaging in genetic diagnostic lab St. Mary. For new AML referral, we use the bone marrow or peripheral blood sample. Both of these DNA and RNA extraction will be done from the sample. DNA extraction will straight away proceed for NGS myeloid panel. LTAT for this is 21 days. DNA also needs to be used for FLT3 ITD, NTKD fragment analysis, and also NPM1 fragment analysis. The LTAT for FLT3 ITD, TKD, and NPM1 fragment analysis is 3 to 5 days, because FLT3 inhibitor therapy can be started on day 8 if FLT3 is detected. At this time, RNA will be extracted for storage and will be used for future baseline MRD testing. After doing the NPM1 fragment analysis and it found positive, we will expedite the NGS myeloid panel to look for the subtype of NPM1, either NPM1A, NPM1B, or NPM1D variant. Once we get the subtype, we will proceed for NPM1 real-time PCR based on the subtype for quantitation using the stored DNA. So for relapse AML or query relapse AML, we will still extract for both DNA and RNA. And for DNA, we will use for NGS myeloid panel. For this, we will need to look for the broader array of mutation status and any change of VAF for the original variant that detected at diagnosis. And also we will proceed for FLT3 ITD and TKD fragment analysis, because new FLT3 mutation could emerge at relapse even if negative at diagnosis. And for the RNA extracted, we will proceed for NPM1 MRD real-time PCR if NPM1 mutation detected at diagnosis. If patient is originally negative for NPM1, we will not proceed for NPM1 MRD. And if detected at diagnosis to have other cytogenetic marker, for example, a translocation, then MRD monitoring done for that particular marker as well. For pediatric AML, at diagnosis and relapse, sample will be processed for FLT3 ITD, NTKD fragment analysis, NPM1 fragment analysis, NGS myeloid panel, whole genome sequencing, and also RNA fusion panel. So now we go into the MRD monitoring AML patient by real-time PCR in Manchester. So we use the real-time quantitative PCR to determine the absolute copy number of specific gene transcript in peripheral blood and bone marrow sample of obtained from AML patient in order to quantify the leukemic gene expression level. And this expression level of this transcript can be used to monitor measurable residual disease because the molecular monitoring has a very significant role in the management of this patient, because MRD level can be used to determine response to treatment, assess refractoriness and resistant to therapy, and as well as predict a potential hematological relapse. So for diagnostic specificity, investigation are analyzed and reported in conjunction with the clinical information and phenotypic data supplied by the clinician. For the diagnostic sensitivity, the assay is most sensitive and performed on more than 10 ml of EDTA blood or 5 ml EDTA bone marrow sample within 24 hours to 48 hours of being taken. And we should know that the ability to amplify at least 10,000 ABL control gene molecules per reaction volume is safeguard against poor sample quality and also for false negative result. However, for inversion 16 and PML RARA assay, minimum requirement of ABL molecule per reaction volume is higher than that, which is 20,000. So this is the molecular MRD for AML done in Manchester, APML with PML RARA, CBF PML with RUNX1 RUNX1T1, CBF H11, and also NPM1 mutation. The fusion transcript are reported normalized to ABL 10 to the power 5 copy using the plasmid standard to generate normalized copy number. And MRD risk threshold for CBF ML, which is run X1T1 and CBF BMYH11, have been established for follow-up monitoring in peripheral blood and bone marrow. So the first one is AML with run X1, run X1T1. This is associated with these fusion genes is due to translocation of 8 to chromosome 8 to 21, which generate this fusion gene. Because of this fusion gene, it direct consequence of the fusion lack of p53 regulation in pre-leukemic cells, leading to proliferation of immature cells. For run X1, run X1T1, there is only one common transcript and the AC hours standardized. And a diagnostic sample is not mandatory as only one breakpoint, but is highly desirable for log reduction calculation. However, rare cases lacking run X1, run X1T1 fusion transcript should undergo further diagnostic workup, possibly including RNA sequencing, as a rare fusion may be present. For example, fusion of run X1 ZFPM2. And it is noted that patients frequently test MRD positive at low level for many years after completion of treatment. And as long as they remain below defined threshold, they are not at risk of relapse. And it is recommended that the MRD testing for run X1, run X1T1 is done at diagnosis, post-induction, post-consolidation, and follow-up for up to 3 years. And the relapse risk threshold for the run X1T1 is 100 copies in peripheral blood, whereas in bone marrow is 500 copies. Anything more than that is considered as possible of relapse, whereas below than that, possible of what we call molecular persistent at low level. So the sensitivity for test of run X1T1 is 2 times 10 to the power of -7 and below consistent with the highest reliability in bone marrow. And sensitivity for the peripheral blood is 10 to the power of 6. So AML with CBFBMYH11, this is caused by the inversion 16 or translocation as chromosome 16, which resulting in a chimeric protein product, which is CBFB-MyH. This protein blocks the differentiation process of myeloid leukemia cells through a sequestration of CBFJ2 in the cytoplasm. However, the expression of this fusion gene alone is not sufficient for leukemogenesis, and additional mutation may be needed to lead to the development of AML. So AML with CBFB-MyH11 also associated with an abnormal eosinophil component, as they carry inversion 16 and therefore derived from the leukemic clone. Similar with the RUNX1T1, patient with the CBFB MYH11 fusion also frequently test MRD positive at low levels for many years after completion of treatment, and as long as they remain below the defined threshold, they are not at risk of relapse. The breakpoint architecture for these fusion genes means there will be more than one amplification, because as we know, there are more than three transcript. However, the most common ones are type A, type D, and E variant, which cover more than 90% of cases. Therefore, a diagnostic sample is mandatory to determine the baseline isoform, and whichever transcript give the highest copy number will then be used to monitor post-induction, post-consolidation, and follow-up for 3 years as MRD. However, if the transcript type has not been established at diagnosis, then all three transcripts must be monitored in the patient. So for this type of fusion gene, the relapse risk threshold in peripheral blood is more than 10 copies, while in bone marrow is 50 copies. Rare variant may also be present, which will give a negative result, as the primer set for this real-time PCR are not be able to detect them. So if rare variant is suspected, further workup, including RNA sequencing, may be required for cryptic rearrangement. So the third one is APML with PMA RARA. This is caused by translocation of PML gene in chromosome 15 and retinoic acid receptor alpha at chromosome 17, which generates the PMA RARA fusion, and this is diagnostic of AML. The PMA RARA fusion gene causes arrested differentiation at the promyelocytic stage. So one of the characteristic of APML is the IVC, this is considered as medical hemato-medical emergency. So treatment with all trans retinoic acid produce remission in more than 90% patients through differentiation and apoptosis of APML cells and correct the coagulopathy. Around 90% of patients are usually detected by cytogenetic and FISH. Therefore, PCR can use to establish diagnosis in patients in which cytogenetics has failed. MRD monitoring also allow preemptive treatment at molecular relapse, for example, ultra or arsenic trioxide, and stem cell transplantation to improve outcome. APML also frequently mistaken for NPM1 mutated AML morphology, which is cup-like nuclei AML. Therefore, rapid screening for NPM1 mutation should be performed in parallel due to clinical urgency and initiation of treatment, because the treatment for AML and NPM1 mutated AML is quite different. So, real-time PCR of diagnostic sample is mandatory in order to accurately establish baseline isoform. There are three isoforms for PMA RARA, which is BCR1, long variant, BCR2, variant, and BCR3, which cover 95% of cases. Whichever transcript give the highest copy number will then be used to monitor post-induction, post-consolidation, and follow-up for 3 years. And again, if the transcript type has not been established at diagnosis, then all three transcripts must be monitored in the patient. And rare variant may also be present, which will give a negative result, as primer set are not be able to detect them. Therefore, further workup is required for patients with abnormal FISH for RARA in the absence of the amplification of PMA RARA fusion by real-time PCR. MRD monitoring AML, there is no relapse risk threshold, unlike RUNX1T1 and CBF MYH11. In APML, if the patient is in remission, but any confirmed positive result following a sustained negative result indicate a high risk of relapse for the patient. Therefore, absolute quantification of transcript is less critical than confidently determine whether this is positive or negative. And also, 2 or more negative real-time PCR bone marrow for at least 1 month apart following completion of therapy is associated with long-term remission. Molecular monitoring also can be extended to mutation screening in the ligand binding domain of PMA RARA, which confer retinoid resistance. From this patient may benefit from additional treatment with ultra or ultra high depth inhibitor combination. So the last one is AML with mutated NPM1. NPM1 is the most frequently mutated gene in cytogenetically normal AML, which present in around 60% of adult AML with normal karyotype. NPM1 is an abundant multifunctional nuclear protein involved in the maintenance of genome stability and ribosome biogenesis. And also shuttling protein, it is also a shuttling protein with a key role in the regulation of adenosine diphosphate ribosylation factor tumor p53 pathway and centrosome duplication. NPM1 mutation are considered as AML initiating lesion, being highly associated with frank leukemia, absent in the clonal hematopoiesis, and detectable in all leukemic cells in patients with NPM1 mutated leukemia. In NPM1 mutation, there will be abnormally localized of NPM1, which the normal place should be in the nucleus, but because of the mutation, the NPM1 now being localized in the cytoplasm of leukemic cell. Because of this, it will further cause uncontrolled proliferation of the neoplastic cell. For NPM1, there are more than 40 different mutations. What most common is type A, B, and D variant, which cover more than 96% of cases. However, NPM1 mutation are prognostically favorable in normal karyotype AML because it makes the neoplastic cell most responsive to chemotherapy. The mechanism is unclear, but NPM1 wild type protect the hematopoietic cell from p53-induced apoptosis in condition of cellular stress, whereas the mutated cytoplasmic NPM1 may fail to protect the neoplastic cell from apoptosis, rendering them more susceptible to chemotherapy-induced apoptosis. So at the moment, NPM1 mutation is the only non-fusion transcript currently clinically validated for MRD monitoring. However, NPM1-AC are more vulnerable to false positive amplification than translocation-based AC. Therefore, baseline mutation should always be identified by Sanger sequencing or NGS. And also, low-level expression of NPM1 mutated transcript is occasionally observed in patients in ongoing remission, and absolute quantification of transcript level is useful in this situation. And accurately determining positive versus negative status is of critically important, especially determining the NPM1's copy number in peripheral blood after cycle 2 of consolidation therapy, when the result is used to allocate patient for either patient needs for transplantation. For NPM1, a qualitative NPM1 test is performed first on diagnostic AML sample, and if it is positive, we need to proceed with the NGS myeloid gene panel again to look for the subtype of the transcript, and then after we get the transcript type, we need to proceed with the MRD monitoring. Again, either the mutation type identified from the previous testing or whichever mutation types give highest copy number will be then used for monitoring. And if the mutation type has not been established at diagnosis, then all three transcript mutation must be monitored in the patient. For NPM1, there is no set relapse risk threshold. However, NPM1 positive patient will have a high level of at diagnosis, which should decrease, which is cause of chemotherapy. If a patient has achieved remission and are molecularly negative and then start to become positive again, this is a sign risk of relapse. So the baseline sample for all MRD monitoring sample requirement, analysis of baseline cDNA sample is strongly recommended for all MRD target and is mandatory for CBF, BMYH11, and PMRRA due to multiple fusion transcript isoform. Run X1, Run X1T1 baseline recommended but is not mandatory. Baseline cDNA sample for NPM1 should be analyzed if available. And rare breakpoint should be considered when suboptimal amplification is observed in the baseline sample. And log reduction calculation are not possible when a baseline cDNA sample has not been tested. So this is the testing recommendation For wild-type control, cDNA synthesis control, PCR no template must all test negative for the target. And real-time PCR should be run up to 50 cycle, and the sample will be run in triplicates. Implication of the target in at least 2 over 3 replicates with a CT less than 40 will be reported as MRD positive, provided all control are negative. And in UK, labs providing AML MRD monitoring should be registered with the UK DCAS AML molecular MRD program with satisfactory performance. So for quality control for the gene, for reporting run X1T1 and NPM1, the ABL housekeeping control gene should have at least 10,000 copies for the test to be set optimum. And for CBFB, MYGC11 and PMRRA, the ABL housekeeping control gene should have at least 20,000 copies. ABL levels lower than 10,000 or 20,000 respectively may be reported with a caution depending on the clinical details provided and assessed on a case-by-case basis. So this is recommended MRD sampling at the time point in treatment pathway. For MRD sampling, it should be done at diagnosis and every time post-consolidation from cycle 1 to cycle 4 for end of treatment, and also at follow-up for up to 2-3 years. For pre-transplant, we will do one MRD testing as well, followed by day 30, day 60, and also day 100, followed by the follow-up MRD up to 3 years as well. So for MRD positivity is defined as amplification of the target in at least 2 of 3 replicates with CT less than 40. Again, provided a control and all controls are negative. An MRD positive sample should be reported as both a copy number and a ratio, which is a target copy number of the target fusion gene divided by ABL copy numbers and times 100, expressed as percentage. So molecular relapse is defined as MRD positive in 2 consecutive samples with a one log increase in transcript expression between the 2 samples in the patient who previously negative. Whereas molecular progression is defined as MRD positivity in 2 consecutive samples with a more than 1 log increase in transcript level, and this should be confirmed with a repeat sample. Molecular persistent at low copy number of persistent molecular disease should be used in cases where at end of treatment or during follow-up, the criteria for molecular relapse or progression are not met. Whereas for MRD negativity, it depends on the sensitivity of the sample. For optimal test, the housekeeping ABL copy number should be more than 10,000 for certain tests and more than 20,000 for certain tests of MRD. If the ABL copy number is around 1,000 to up to 10,000 is suboptimal, but if less than 1,000, it's considered failed. Molecular complete remission defined as lack of target application in 2 consecutive bone marrow samples with optimal sensitivity. For suboptimal and failed samples should be repeated ideally from RNA extraction if there is sufficient sample. This is just the summary of the reporting sample taken during treatment and after transplantation. Okay, this is one paper produced by one of my colleagues in UK regarding the minimal residual disease monitoring by RT-PCR in CBF AML in UK, AML 15 trial, which tells about the CABF MRD thresholds. Again, this is the threshold predictive of relapse in CBF AML, and also for PMR-RARA reporting. Okay. The most important thing about NPM1 is reporting of post-consolidation to peripheral blood. In UK, post-consolidation to peripheral blood is the most prognostically important result. In UK, this result is used to select the patient who should undergo bone marrow transplant in first remission. Again, the positive result, which is 2 over 3 replicates with a CT less than 40, should be reported as MRD positive blood after 2 cycles of intensive chemotherapy is associated with high risk of relapse. whereas negative result should be reported as MRD negative blood after 2 cycles of intensive chemotherapy is associated with low risk of relapse. This is the NPM1 reporting of end of treatment samples. For molecular persistent at low copy number, the copy number for NPM1 is less than 1,000 copies over 10 of FPL1, whereas molecular progression means that the NPM1 copy number is increased to more than 1,000 copy or more than one log increase between 2 consecutive samples. Now I'm going to what we do with the reporting. For example, in new case of AML, we will do again the myeloid NGS fragment analysis for FLT3, ITD, TKD, and NPM1. For example, this is NPM1 fragment analysis report. For this patient, the NPM1 is positive. However, we cannot say what type of this NPM1 that has been detected. So what we can do is we will expedite the NGS myeloid panel to identify the subtype of transcript. So the same patient, this is the result of the NGS. As we can see, NPM1 is detected, and from the variant, this is type A of NPM1. So now we can proceed with the baseline of NPM1 real-time PCR for subsequent MRD monitoring and quantify of the transcript number of the NPM1 mutation. So this is the result of MRD real-time PCR of NPM1. So for example, for this one show high level of the NPM1 type A transcript. So the result will be plotted on graph so that it is easy for the clinician to continuously monitor the level of the copy number of the mutated gene. So for each graph, there will be a graph interpretation that will be put at the back of the result. So each molecular MRD test, there will be a different graph interpretation. So this is, for example, the NPM1 that cannot be quantifiable. Quantifiable means in triplicate sample, 2 of them will have the CT value of more than 40, but one of the result will have the CT value of less than 40, but the copy number is only less than 5. Therefore, we will say that this is it is detected but unquantifiable. This is what they mean by unquantifiable. Again, in this graph, as you can see, there are 2 types of color. One is in blue in diamond shape, means this is from the peripheral blood, while square pink color is actually from the bone marrow. So the green diamond is sensitivity for the peripheral blood, and the green diamond is the sensitivity of the test for the bone marrow. And this is the NPM1 MRD that is not detected. So the plot, this is the MRD negative for NPM1. So for this patient shows the molecular relapse for NPM1. Patient actually already achieved the complete remission in November 2022, but in January 2022, patient already has molecular relapse where there is a 7 increase in log compared to the previous sample for bone marrow. For the bone, this is also being confirmed by the result of the peripheral blood. So this is for the AML PMR diagnostic sample. This is showing the AML MRD PMR that respond to therapy. And for this patient, at first patient already achieved complete remission. However, after subsequent MRD testing, the bone marrow result show there is a 3-log increase in the copy number of the PMRRA, which is consistent with the molecular relapse. In PMRRA, it should be always remembered that there is no persistent low molecular level. If it is positive from the negative result, we should consider as relapse. This is for the undetectable transcript for PMRRA. This is what we call persistent low transcript below relapse threshold. Remember that there are different relapse threshold for peripheral blood and bone marrow. For peripheral blood, it is indicated by the red line, whereas for the bone marrow, it is indicated by the cyan line. So in this patient, he always had a persistent low transcript below the relapse threshold of the bone marrow. So again, the pink square is indicate that sample is taken from the bone marrow. So as long as it does not exceed the bone marrow or peripheral blood threshold, we will consider, and patient is asymptomatic, we will consider as persistent low transcript below relapse threshold. And this is not indicate that patient has relapse, but close monitoring is advised. This is another sample of patient who had persistent low transcript below relapse threshold, where at first the patient had response where the copy number is just touch the bone marrow relapse threshold, peripheral blood relapse threshold. However, it does not exceed the bone marrow relapse threshold. So this is what we call low prescript below persistent low transcript below relapse threshold. Again, this is for AML, MRD, CBFA, MYH11. Comparing diagnostic and post-induction, showing there is a reduce of the copy number, but still not the copy number is still not below the relapse threshold. And this is showing that there is a response of the patient towards chemotherapy by continuous reduction of the gene copy number. And if the fair result, we will report because of the low ABL housekeeping gene level. So we will still report, but we will see that the housekeeping gene for the sample was lower than the recognized acceptable level for reporting, and the sample failed quality control. So we will ask them to repeat the analysis, either using the peripheral blood or bone marrow. If in Manchester, we have weekly MDT session where we have discussion between the molecular hemato-oncology team with clinical hematologists from various hospitals, which include Manchester Royal Infirmary, Christie, Wythenshawe, and Salford. And we will do it every Thursday at 3:30 p.m. to 4:30 p.m. So by doing MDT, we can discuss all interesting cases between the clinician with hemato-oncology molecular team, which focus on the molecular findings of the patients. So that's all. This is my team in Manchester. Thank you and selamat berpuasa. That's all.
Okay, thank you very much to Dr. Siti Fatimah. I hope you all can hear me now. Okay, I'm very sorry for the technical problem earlier on. Okay, I think there's question in the chat box from Dr. Muhammad Fazil. The first, he has two questions. The first one, are these advanced tests, especially the MRD, RT-PCR, available in any MOH facility?
At the moment, we have in Hospital Ampang, which offer the MRD real-time PCR, Coran X1T1, I think for all that tests that I mentioned before, except that we don't do the protocol like in Manchester, because for diagnostic tests, we will send all the tests to NIH. So it is difficult for us to do the real-time PCR for baseline MRD testing because all DNA or RNA is already sent to NIH instead of Hospital Ampang. For Manchester, I think it is easy for them because they're only in one place to do everything.
Okay. Question number 2. Does MOH formulary for acute leukemia protocol is adjustable as per molecular result?
For this, I think at the moment kita memang ada formula for MRD molecular result monitoring and treatment accordingly. But I don't know whether we can adjust at our own decision ataupun kita memang ada specific protocol to follow as molecular result.
Okay. Right. Maybe going back to the question number 1, because meaning that you have the service in Ampang and NIH. Sorry, because I'm chemical pathologist, I'm not really well versed with it. Okay, so is there any plan to expand the test or to meaning that for you to make it better in terms of coordination so that you can proceed further with whatever that like Manchester's doing?
Actually, the best practice is kita buat macam one center to do everything for the molecular test. In my opinion lah, it is better to have one center to do everything, just like Manchester, so that macam kita tak ada different place to do different tests for molecular testing. For example, macam saya cakap, diagnostic test kita akan buat dekat NIH. Let's say kalau dekat NIH kita kata NPM1 is positive, and sampel tu akan ada di NIH. So kita akan ambil a different type of sample yang kena hantar dekat Hospital Ampang untuk buat quantification. So kalau dah different, kalau patient tu dah being treated with chemotherapy, and then yang sample yang kita hantar kepada Ampang untuk quantification tu dia bukan dah jadi baseline punya test. Dia dah jadi macam subsequent punya test, and dia punya result might not be accurate lah untuk dia punya. And also kita tak dapat dia punya accurate dia punya transcript. So macam dekat Manchester, if kita tak dapat transcript dia daripada diagnostic sample, kita terpaksa buat 3 transcript tu guna 3 different primers.
So probably, I mean, I don't know in future probably it can be a center, I mean, one stop center sort of for this service. Bhaskaran has raised hand. Any question? You can unmute yourself. Okay. Any other question from the audience or any comment?
Maybe audience pening sebab this is like molecule is very like
yeah. Or any senior hematologist would like to give any comment to the presentation? Dr. Siti Fatimah, I'm also, I just wonder how much does it cost for this test roughly?
For AML, MRD, I'm not too sure, but for diagnostic, around 1,000 plus for each test. This is for diagnostic leukemia translocation study. But for MRD, I'm not too sure.
Okay. Is there any more questions? Anything you want to ask? You have the chance. You have the expert here to answer. I think tak ada aku Dr. Fatimah. Or you any last word from you regarding the topic?
in Malaysia, our molecular is not as macam canggih lah macam dekat UK. But I hope our molecular service in Malaysia will expand and develop more in future, so that we can help our hemato patient dengan lebih baik lah. Hopefully, insyaAllah.
Okay, alright, okay. I think there's no more question or comment from the audience. So, on behalf of the pathology fraternity, I would like to say thank you very much to Dr. Siti Fatimah for your effort to complete your AOI in AOI training and as well as come back hopefully to improve hematology service further, definitely. So to everyone, thank you for joining this CME. Dan to all Muslims, selamat berpuasa. Dr. Nick, is there anything you want to add before we end the session?
Tak ada check away from me.
Alright. Okay, in that case, okay, till we meet again next session. Thank you very much.
Thank you, everyone.